My name is Macy Way, and I chose bacterial endocarditis for my topic for the oral presentation. Like it says in the name, bacterial, it's a bacteria infection, mostly caused around the heart. My point of view on it is that for high-risk patients, if it's not treated very quickly, it can be very dangerous to them. So what exactly is bacterial endocarditis? It's also called infective carditis. It's an infection of bacteria that enters the bloodstream that may settle in a heart valve, blood vessel, or the heart lining. It's uncommon, but people with heart conditions are more high-risk patients. If you don't have a heart disease, you probably won't see it near as often, but it's obviously common if you do have a heart disease. How does a person get this disease? The bacteria enters the bloodstream. Examples such as brushing the teeth, if you have mouth sores, bleeding gums are an easy access place for it. Poor dental hygiene, mainly anything to do with the mouth, are prime suspects due to you're brushing your teeth, it's going down, the saliva, everything, it's going that way in the heart's direction, and it could settle by your heart. Diagnosis, you have an echocardiogram, that's to view the valves of the blood flow through the heart, blood tests and cultures to check for the bacteria and signs of an infection, an EKG to analyze the heart rhythm, chest x-ray to examine the lungs, make sure you're not having any hard time breathing, a cardiac CT if more info is needed about the patient's heart, urine test, checking for kidney damage, and an MRI of the brain, checking for brain damage. And I got that off the Mayo Clinic website. The causative agent for bacterial endocarditis is Staphylococcus aureus, followed by Verdens streptococcus, and coagulase negative Staphylococcus are most common organisms for this infection. The type of agent is bacteria like in the name. Also, Staphylococcus aureus is a bacteria also, like we talked about in lab. Both of these we talked about and we learned about. Characteristics of this disease is flu-like symptoms, fatigue, night sweats, shortness of breath, change or new heart murmur once discovered, chest pain, swelling in feet or abdomen, blood and urine, and headache, and rapid weight gain. So right here is a microscope view of bacterial endocarditis. Right here is the cells inflamed, these dots. And then the dark purple over here is the masses of bacteria, the violet color. The fibrin strands, it's mainly neutrophil leukocytes. Right here's the myocardium. And this basically is what you would see if you was to have this on a slide and we were looking at it under the microscope. So right here is in the endocardium of the heart. This is all this white stuff right here is all infection. So the microbiology of it is equal rates of the Staphylococcus aureus, the enterococci, the coagulase negative Staphylococci, like I said earlier. The culture negative is rare. A majority of the healthcare associated, so if you're in the hospital, it's kind of more common to see that in a healthcare setting. Risk factors are younger age, the male sex, chronic kidney disease, higher surgical risk, valve-in-valve. Outcomes of this is in hospital mortality is less than 30%. Worst outcomes associated is shock, heart failure, and acute kidney injury. Recurrent infection is common, less than or higher than 10%. Prevention is antibiotic prophylaxis, patient education, avoidance of invasive procedures, and monitoring of high-risk patients. Treatment for this is depending on what type of bacteria, depends on what kind of treatment they're going to follow through with. Number one being antibiotics, antibiotic IV drip, and surgery may be necessary if there's so much bacteria in there that needs to be taken out. So penicillin 18 to 30 per day, and 1 milligram every 8 hours of gentamicin. Ampicillin 12 grams a day, and gentamicin 1 milligram 8 hours. Vancomycin 15 milligrams every 8 hours, and gentamicin 1 milligram every 8 hours. I got this information off the American Family Physician website. The use of high levels of antibiotics over an extended time is necessary to eradicate these organisms, even when there is a good in vitro sensitivity to the antibiotic. The challenge is greater when the infecting organism has reduced sensitivity to antibiotics. The choice of antibiotic therapy is based on several factors, including the identity of the infecting organism, the profile of antibiotic sensitivity of the organism, the pharmacokinetics of antibiotic agents, and the individual characteristics of the patient. So therefore, they're going to look at, is this patient high risk? Does the patient already have underlying health issues? Are they allergic to certain medications, antibiotics? What kind of organism it is that's growing that they're going to be able to look at, such as under the microscope, see what kind of organism's growing to find the right antibiotic to treat this patient. Possible complications is heart failure, valve damage, heart attack and or block, a brain abscess, meningitis, seizures and or stroke, and a pulmonary embolism. I got this off Cedars Sinai website. And that is all for my presentation.